Good afternoon, everyone. My name is Nancy Kelly from the New England QIN-QIO, and I'll be your moderator for today's webinar, Million Hearts 2022 and Best Practices for Hypertension Control. Thank you for joining us for today. Before we get started, just a couple of quick housekeeping items. This call will be recorded for training purposes, and I'll provide you details on how you can access the recording at the end of this webinar. Also, the phone lines will be on mute for the duration of the presentation. However, we will take questions at the end of the presentation, and I'll provide you instructions on how you can ask a question either over the phone, or you can also pose a question in the chat box in the WebEx system. So at this time, I'd like to introduce our presenters for today's webinar. Georgette Verhel is from the New England QIN-QIO, and she's also the state lead in New Hampshire for the Cardiovascular Initiative, as well as supporting the Quality Payment Program Initiative. Along with Georgette, Adrienne Burke will be presenting today as well. She's a program planner at New Hampshire's Division of Public Health Services, where she focuses on health systems, quality improvement, and hypertension control across the state. At this time, I'd like to hand it over to Adrienne, who will be kicking off the webinar presentation for us today. Adrienne? Hi, Adrienne, are you there? I think you might hit #6 on your phone.
Hi, everyone. Thank you for joining us today. So I'm going to present on the Million Hearts 2022 campaign. Then Georgette will go into some of the things we've been doing in New Hampshire, and I will finish off with the self-measured blood pressure program that we've been doing in New Hampshire here. So to start today's presentation, I'm going to discuss the Million Hearts 2022 campaign. As many of you probably already know, this is the second phase of the Million Hearts project. The first phase was from the beginning of 2012 through the end of 2016. And that first phase of the program encompassed many of the same strategies we'll be talking about here today. So in the Million Hearts 2022 campaign, the aim is to prevent 1 million or more heart attacks and strokes in the next 5 years. It's a national initiative, and it is led by the Centers for Disease Control and Prevention and the Centers for Medicare and Medicaid Services. There are also many partners across the U.S. that are also joining the initiative. During the first phase, there were 120 partners, as well as all 50 states who joined the initiative. For this campaign, it's just kicking off, so we're still waiting to see what that's going to look like. So why is this important? Why are we focusing on heart disease and stroke? Each year in the U.S., more than 800,000 adults die from cardiovascular disease, and 1.5 million have a heart attack or a stroke. It's the leading cause of potentially preventable death in the U.S., and the cost is over $300 billion every year in both medical costs and lost productivity. Let's see. It's also the greatest contributor to racial disparities in life expectancy, especially among African Americans. And after 40 years of steady improvement, the rates of decline in both heart disease and stroke have slowed down, which is another reason we want to focus on this today. So a lot of those initial changes were due to changes in the environment, such as fewer people smoking and improvements to clinical care. But there's still a lot that we can do to keep this moving forward. So here's the framework for Million Hearts 2022. In order to prevent the 1 million heart attacks and strokes by 2022, there are 3 key priorities that we're going to focus on. The first is keeping people healthy. That's the outer box here. And we're going to do that by making changes to the environment where people live, learn, work, and play, so that it's easier for people to make healthy choices. And then we're going to optimize care, so that's in your clinical environment. And we're going to do that for people who are at risk for cardiovascular disease and receive services and acquire the skills needed to reduce the likelihood of having a heart attack or stroke. And then finally, we're going to improve the outcomes for priority populations. That includes folks who are African American, people who are, I believe, between 35 and 64, who are seeing rates increase. And then I will get into each of these 3 categories a little bit more in the upcoming slides. So here's how we're going to address each of them. In this first maroon box, we can see the keeping people healthy box, and we want to do this by reducing sodium intake, decreasing tobacco use, and increasing physical activity. We want to increase all of those, or decrease all of those by 20%. The next box, the purple one, optimizing care. We want to improve the ABCSs, which is aspirin when appropriate. The B is blood pressure control. C is cholesterol management. And S is smoking cessation. And we want to increase all of those up to about 80%. We want to increase the use of cardiac rehab. Currently, less than 30% of people are 30% of people who are eligible for cardiac rehab are actually going. The goal for this upcoming 5-year period is to get that up to 70%. And if we do that, we believe it will prevent 25,000 deaths and 180,000 hospitalizations each year. So that's one of the big ways that we can get to our goal. Finally, improving outcomes for priority populations, the bottom box here. We're going to focus on Blacks and African Americans, people who are 35 to 64 years old, people who have previously had a heart attack or stroke, and people with mental illness or substance use disorders. So again, looking at that the first box of the second box, effective public health strategies. Again, we want to reduce sodium intake, decrease tobacco use, and increase physical activity. So to get to the goal of 20% reduction, we're going to focus our efforts on the public health strategies listed on the right. So for sodium intake, we want to focus on local food procurement policies, enhance choices for lower sodium foods, and encourage producers to offer lower sodium alternatives. Decreasing tobacco use, this is a lot of the stuff that we've been doing in the past, but increasing smoke-free spaces and using pricing approaches to encourage people to quit. And then finally, increasing physical activity. We want to make the environment around people more conducive to being healthy. So increase access to places for physical activity, designing communities with physical activity in mind, and then creating and supporting peer activities such as walking groups. So for optimizing care, again, this is mostly the clinical. We want to use these effective healthcare strategies on the right to affect the goals on the left. For technology, we want to improve electronic health records and have people use clinical decision support, patient portals, and other technology to improve care of their patients. We want to increase the use of teams in the healthcare setting. So include your pharmacists, your nurses, other folks who haven't historically been used as much as they should be or could be, including community health workers and cardiac rehab professionals. For processes, increase the use of treatment protocols, daily huddles, scorecards, outreach, and then patient and family support. So training in the home for blood pressure monitoring, and problem solving for medication adherence. Improving the outcomes for priority populations. Again, I mentioned this previously. There are certain populations we want to focus on, including Blacks and African Americans, those who are 35 to 64, because events are rising in that population, people who've had a heart attack or stroke, and people with a mental illness or substance use disorder. And you can see on the right here that the strategy for each of these is slightly different in how we want to address those populations. So the Million Hearts website has lots of resources and tools that you can use to address hypertension and other heart disease and stroke-related issues. On their website, I strongly encourage you to go and take a look at what they have there. And then stay connected. And you can also find these on the Million Hearts website, but there's e-update newsletters. You can follow them on Facebook. Again, look on their website. And then they also have a clinician's microsite. All right, I'm going to pass this over to Georgette here to do the next segment of the presentation.
Thank you, Adrienne. I'm going to talk a little bit about accurate blood pressure measurement, saving lives, and the best practices. So the objectives are to be able to list the classifications of blood pressure, to use correct patient positioning for an accurate blood pressure measurement, that is key, to be able to select the correct size blood pressure cuff for accurate measurement, and to identify at least 3 lifestyle modifications that you could discuss with your patients who have pre-hypertension or hypertension. So what is blood pressure? I think we all know what this is. It's the force of blood against the walls of the artery. It's recorded as 2 numbers, your systolic and your diastolic, and hypertension is persistently high blood pressure. So the blood pressure classifications, this is according to the American Heart Association. So normal, in a perfect world, would be 120/80 or less. Pre-hypertension in the middle, that's the range of 120/39 or 80/89. High blood pressure is considered 140/159, over 90/99, and very high blood pressure is 160 or higher, over 100. So why is this important? Why is it important to take a blood pressure correctly? Well, in 2013, high blood pressure was a primary or contributing cause of death for more than 360,000 Americans. That's nearly 1,000 deaths per day, and that's from the Million Hearts website. Hypertension also increases one's risk of heart disease, stroke, and kidney disease, as well as early death. 1 in 3 U.S. adults actually have high blood pressure, and only half have their condition under control. And also, inaccurate blood pressure measurement can definitely lead to misdiagnosis of hypertension. So this is a couple of pictures of patient positioning. It's very important to have your feet flat, legs uncrossed, back should be supported. Your arms should be exposed and level with the heart. This is a classic example of not, you shouldn't be going over people's sleeves and doing things like that. The patient shouldn't be talking during the measurement, and also they shouldn't be actively listening because that kind of distraction can cause their blood pressure to be a little higher than it might normally be. Definitely avoid smoking 30 minutes prior to measurement, and you shouldn't have a full bladder. So arm selection, these are some of the things that you need to avoid. If you're taking the blood pressure, if there's pain or injury in the arm, if they've had breast or axillary surgery, including a mastectomy, if they have an IV or an arterial line in. Always check your equipment. This is, I've been to many, many places where I've had them bring out their equipment, and I found that they're not calibrated. As you can see, visually inspect your cuff and your sphygmomanometer, never an easy word to say. Your arrow should be within that 0 box prior to installation. If it's not, you should take the unit out of service, get it fixed, or replace it. And ideally, manual blood pressure is still the best. Selecting the correct cuff size for readings to be accurate, you should place the blood pressure cuff on the patient's arm so that the index line falls within range. And the next slide will show you, yes, here we have cuff is too big. You can see where that index line falls. It's a little to the left of the range, and if it's too small, it will fall to the right of the range. And these can lead to inaccurate blood pressure readings of being either too low or too high. So this is another picture just showing you a correct cuff size and the correct placement. Of course, the cuff should be snug around the arm. You should be able to fit 2 fingers up underneath it, though, so it's not too snug. You don't want a tourniquet effect. And it should be about 1 inch above the antecubital fossa. And these are some things you should avoid. If the sleeve that you're pushing up becomes too tight, that can be a tourniquet effect. And again, if you go over or try to listen through clothing, you're going to get some muffled sounds or not necessarily sounds that you want to hear. So the cost of making small measurement errors, that can result in either undiagnosed cases of hypertension, which, that's under treatment, or misdiagnosed cases of hypertension in patients who are really pre-hypertensive, and that can lead to overtreatment. So these are some of the factors affecting accuracy of blood pressure measurements. I'll just give you a few seconds to take a look at that. But these things can make a difference. So obtaining and recording an accurate blood pressure, this just talks again about applying the cuff snugly around the arm and inch above the antecubital fossa. Inflate the cuff, and you should deflate the cuff at like 2 to 3 millimeters per mercury per second. A lot of times I've experienced people deflating the cuff rather rapidly, and I'm not sure how they could hear your first or, that first sound or so, the systolic pressure, which is your first sound that you hear. And both methods here above are recognized standards. Always refer to your agency's policy and procedure. And then again, listen for another 10 to 20 millimeters per mercury beyond the last sound heard. And after that, quickly deflate the cuff. So record and recheck as needed. Should definitely wait at least 5 minutes in between blood pressure readings. Notify the provider of all readings of concern. I know some agencies have the practice where they will put a red heart outside the door to just alert the provider that the blood pressure was elevated. But again, always follow your agency's BP policy and procedure. So what can your practice do to ensure accurate blood pressure measurement? Well, develop a policy, that's first and foremost. Always provide staff training. Do some competency testing. Calibrate your blood pressure equipment, and rearrange furniture in exam rooms to accurately take a BP. I've seen some practices move the chair that the patient's sitting in so that it's closer to the exam table so that their arms can be supported while they're taking the blood pressure. And always be sure to position your patient properly. So some lifestyle modifications you can talk with your patients about. Of course, always take your blood pressure medication as prescribed, and don't skip without consulting your provider. Don't skip a dose. Maintain normal body weight. Eat a healthy diet. Should be high in fruits and vegetables, low in fat. Reduce your salt intake. Physical activity, at least 30 minutes most days. Limit alcohol use. Avoid tobacco. Manage your stress and your diabetes. And have your blood pressure checked regularly, and consider self-monitoring, which is something Adrian's going to talk to in a few minutes about. So here's a case study. Judy is a 50-year-old African-American woman who is 5'2" and weighs 180 pounds with a BMI of 33. She's an administrative assistant at a large insurance agency and does not exercise on a regular basis. She's a diabetic and smokes 1 pack of cigarettes per day, and her blood pressure was 180/92 today. So think about this for a minute and see if you can come up with at least 4 of Judy's risk factors. Well, how'd you do? Let's see. First of all, we've got that Judy is an African-American woman. Her BMI is 33. She doesn't exercise regularly. She's a diabetic, and she smokes 1 pack of cigarettes per day. Those are some of her risk factors. So what are 3 lifestyle modifications that Judy could try to help lower her blood pressure? So again, we talked about these earlier. Physical activity at least 30 minutes most days. Avoiding tobacco, manage stress and diabetes, so maybe Judy needs to get her diabetes under control. Who knows? Maintain a normal body weight. These are all lifestyle modifications to discuss with patients. So I do want to acknowledge Dr. Rudy Fedrizzi. He's the Director of Community Health Clinical Integration and Education, as well as Training and Development Department at Cheshire Medical Center in Keene. He graciously has shared these slides with the Department of Public Health as well as us, and also thanks to the New Hampshire Department of Public Health for their contribution. Some of the updates to the slides were using the Million Hearts website as well as the American Heart Association website. And there's a list of references. And my contact information if you are interested in doing lunch and learns here in New Hampshire, where we can help your staff be sure that they're taking blood pressures correctly and take a look at your equipment and all kinds of fun things. And with that, I'm going to turn this back over to Adrian.
Trisha, can you send me? Thank you. Hello again. So I wanted to discuss with you one of the ways that we are addressing or working towards the Million Hearts goal here in New Hampshire. We have a real focus on hypertension, which is why Georgette presented on the proper way to take up blood pressure. That's one of the ways that we've been doing it, is going around to clinics and discussing with providers and nurses and MAs on the proper method. But we've also been working toward increasing self-measured blood pressure here in New Hampshire. So the New England QIN-QIO and I have been collaboratively working on this project, and so I will detail it a little bit for you here. So what is self-measured blood pressure? It is the regular measurement of blood pressure by the patient outside of the clinical setting, which is usually at home or somewhere else, but primarily at home. And it requires the use of a home blood pressure monitor so that the patient can measure their blood pressure at different points during the day. And there's really strong evidence to support the use of self-measured blood pressure, especially when it's tied with clinical support. And I'll get into that evidence a little bit more in the following slides. So there are some of the benefits are that many results are yielded over time with fewer office visits than would otherwise be needed. These can help determine if a change in therapy is needed, and it can prevent overtreatment. It can improve blood pressure control, especially when used with clinical support, and it can improve adherence to antihypertensive medication. And a lot of this is because the patient's sitting at home taking their blood pressure a few times a day, which makes them more involved in their care. So they're more likely to take their medication, for instance. Let's see, Georgia talked a little bit about this earlier, but one of the reasons we're looking at self-measured blood pressure here in New Hampshire as well as across the country is that 1/3 of Americans have hypertension, and only about half of those are under control. And then there's a huge cost associated with it. And then here in New Hampshire, I only had federally qualified health center data to go by, but if you look at this pie chart on the left, the yellow one, you can see that about 25% of patients at the federally qualified health centers combined in New Hampshire have hypertension, and about 33% of those are uncontrolled. And we're working with mostly FQHCs on this SMBP project. So here are some of the recommendations around SMBP. The community guide recommends it both when used alone, but also in combination with additional support. AHRQ, their comparative effectiveness study in 2012 recommends it, as well as the USPSTF. They consider it an A-level recommendation, and that is for diagnostic confirmation. So we're still trying to get some clarification on that and trying to understand insurance coverage, because a lot of insurance companies don't cover these monitors for patients. There's also a joint scientific study from the American Heart Association, the American Society of Hypertension, and the Preventive Cardiovascular Nurses Association that supports the use of SMBP. And then there's lots of other partners as well. As we talked about, the Million Hearts Project, the American Medical Association, the American Heart Association, and then CDC's 618 initiative all recommend the use of SMBP. So what are we doing here in New Hampshire? So as you know, there's evidence to support the use of this. Insurance coverage is spotty and unclear. And we had an identified need in the states. Clinics were asking us if we could provide these monitors for patients. And so we were able to obtain some funding to partner with the New England QIN-QIO to help start a program. So to get started, we worked with about 13 clinics that we consider pilot sites. These were all clinics who had previously participated in a hypertension quality improvement project, so we knew that they were interested in this area. Each clinic had to apply to the program and be accepted into the program. And then monitors were sent out in September of 2016. And then once they received their monitors, each clinic had to develop a procedure document detailing how they were going to use the monitors, how they were going to identify patients that they would give or lend the monitors to, how they would be stored, how they would be calibrated, that sort of thing. And then they were able to start handing out monitors and collecting data. Again, here were some of the program requirements. The first was to develop a written procedure. They had to develop patient or identify patient education materials to give their patients. And then they had to report back data at 6 months and 12 months to us, the Department of Public Health as well as the QIN-QIO. And each program started sort of on a rolling basis, so not every clinic hit 6 months and 12 months at the same time. We gave these resources to clinics to help understand the benefits of SMBP and what a good procedure manual looks like, what can be included in it, and some best practices. The first one here is the American Medical Association and Johns Hopkins Guide for engaging patients in self-measurement. And then the following two are Million Hearts Program documents. One is for clinicians and the other is for public health professionals. If you're interested, I strongly encourage you to look at these. There are some really great resources in them. And then we started getting some data back. This is just two of the clinics. But as you can see for the first one, Clinic A, 31 patients were enrolled in the program. 24 of those patients saw a reduction in blood pressure at 6 months, and 15 of them are now in control. For Clinic B, 26 patients were enrolled, 20 had a reduction in their blood pressure, and 14 are now in control, which are really exciting results. So we just started phase 2 of this program. We just sent the applications out about a week or two ago. And we've broadened this, so any clinic in the state is now open to apply. If you are a clinic in New Hampshire and you did not receive an email from us, please email either myself or Georgette, and we'd be happy to send the application along to you. The applications are due back on November 7th. So that concludes my presentation. So I guess we will open it up for questions if anyone has any questions for either Georgette and myself.
Yes, thank you, Adrienne, and thank you, Georgette. So at this time, we'd be happy to take some questions. If you'd like to ask a question, you can either post one in the chat box you'll see on the right side of your screen, or you may also press #6 to unmute your line. And Adrienne and Georgette, I think we actually do have a question in chat. I'm happy to read it out for you if you like, from Susan Whitaker. She's asking, does the ideal blood pressure range for people over age 65 differ from the one mentioned in the slide?
Hi, it's Georgette. The slides are in keeping with the American Heart Association, so, I think it's really something important that people of all ages need to discuss with their providers and find out what their recommendations are.
Okay, and once again, if you'd like to ask a question, you can add it in the chat box or press #6 to unmute your telephone line. Okay, we'll give one more minute if anyone else has questions they'd like to ask for Adrienne or Georgette. Let's go #6 on your phone.
Hi, I just saw the question in the chat box. What is the time frame for you to work with a patient who is enrolled into the program? So with this program, we really decided to leave it up to the clinics to decide how they wanted to work with their patients. Ideally, we were thinking the entire 12-month period, but each clinic is a little bit different based on their patients' needs and their patient population. And one thing that I did not mention is that some clinics did a giving program where they gave the monitors to patients to keep, and other clinics decided that they really valued having the monitors on site, and they knew that they probably weren't going to be able to get any additional monitors or funding in the future, so they decided to do a lending program where they gave the monitors to a patient for a certain amount of time when they were needed, and then the patient returned them back to the clinic. They were cleaned and given to another patient. There is a list of approved home monitors available, and if you go into, I believe it's the Johns Hopkins AMA guide, they have a list in there of, or a link to where they have all of the basically certified blood pressure monitors, and I think it changes periodically. But we decided to go with the Omron 5 monitors, which were on the list. And so we purchased those and gave them to clinics. And then I believe that there are programs going on in other states. I'm sure they differ a little bit from ours, but I think that some of the New England states are. Connecticut comes to mind.
Okay, if anyone else would like to ask a question, let's get it to pound 6, or you can continue to use the chat log as well.
And then if anyone has any questions about the self-measured blood pressure program, I encourage you to call or email either myself or Georgette. We'd be happy to talk through more in detail what we did here in New Hampshire. So please don't hesitate to get in touch with us.
Okay, fantastic. So without any further questions, I'm just going to go ahead and do some last few closing announcements. Just wanted to note, too, with everyone on the call that we are, the New England QIN-QIO is on social media, so you can find us on Facebook, LinkedIn, and Twitter. Here you can get the latest resources, webinars, and other offerings such as online sessions and in-person sessions that we are hosting across the region. Now back to this webinar, when you close out today, the evaluation will automatically pop up on your computer. We encourage you to fill that out. It'd be greatly appreciated to have your feedback. And if you don't have time to fill out the evaluation right now, or if you're looking at the webinar on another computer with someone else, you'll actually receive an email tomorrow morning with a link to the evaluation as well. And you'll also have a link to the event page on our website, which also houses the presentation from today, which I also included in the chat box. That presentation was in an email you should have received this morning. In addition to the PowerPoint on our website, the recording and the transcript from this webinar will also be added midweek next week, so you can share it with others if they were not able to attend live today. So thank you all for attending today, and we hope you have a great day.